We're going to now discuss some disorders of growth, and when we divide disorders of growth, we talk about height and weight. Okay, we're not talking, growth is actually an increase in size. We're not going to talk about development, that's acquisition of function. So we're going to talk about growth today, and that's going to be an increase in size. It's either you get taller or you gain weight. And so we talk about disorders of height, disorders of weight. Under disorders of height, we're going to discuss short stature and tall stature. Under disorders of weight, we talk about failure to thrive or malnutrition, or the other end of the spectrum being obesity. It's important to have the growth curve. The more points that you have, the easier it is to see a trend. And you're going to see basically 3 trends when it comes to short stature. So we're going to talk about a patient that's basically below the 3rd to 5th percentile in the growth curve. Here this patient is around the 10th percentile, so a little bit on the shorter side, even though it is the normal side. In this particular case, we're talking about familial short stature. You're going to look for a history of everyone in the family, or a lot of the people in the family, being short. It means the parents are short, the siblings are short, the grandparents are short, the aunts and uncles are short. They're all short. That means that genetically you don't have a whole lot of material to be tall, and so you will tend to be short. An important clue here is that even though the patient is short, don't look at the weight, because the weight is different. We're talking about stature now. The patient is going parallel to the growth curves. So you can see there that the patient is showing steady gain in height and is on the short side, but still parallel to the growth curve. That's an important thing to remember when you're evaluating the table. A test question could conceivably be, they show you a growth curve, or they present you a child and then give you a growth curve, and you'll have to decide what kind of growth pattern this is. This is going to be familial short stature, history of shortness in the family, and the patient is going along in a parallel manner to the growth curve. This is the second type, which is called constitutional growth delay. In this particular case, you're going to see that the patient is below the percentiles, but at some point starts to take off and ends up in the normal range. You may get a history of a patient that has normal-sized or tall parents, and you will probably get a history of a delay in the growth spurt in one or the other parent. So they might say that the dad was a late bloomer and didn't have his growth spurt till later on in life. The physical exam on this child will be normal. Now, we finished talking in the previous chapter about genetics and dysmorphology, and some patients, some syndromes or whatever, will go along with short stature, but you'll have other findings. In this particular case, we have a child that is otherwise absolutely normal, has no past medical history, and the parents are normal height, and maybe one or the other was a late bloomer. If you're given that growth curve, think right away of constitutional growth delay. A very important test to grab here is going to be the bone age. And you're going to see with constitutional growth delay that the bone age is less than the chronologic age. What that tells you is, for example, if the child is 13 years old and they do a bone age and the child is 11 on the bone age, that means that there is room to grow, and it's most likely constitutional growth delay. You just need to reassure the parents. This is more, the third growth pattern that you need to know is more of a pathologic problem. The key here is that the patient may be actually in the normal range and then starts going across growth percentiles. So you'll see on the growth chart, this patient basically was at about the 50th percentile and then starts going, drops down to percentile, and then is kind of parallel for a while, and then all of a sudden, boom, really cuts across percentiles. This patient has acquired hypothyroidism. It's not always hypothyroidism, it could be some other disease, but this is a patient that's going across the percentiles. This is more of a pathologic problem. Once the patient has thyroid hormone replaced, then you can see right there the growth just takes off right away again. So look for a patient with some kind of pathologic problem that is going across the percentiles and falling off the growth curve. This is Robert Pershing Wadlow. He's like the tallest human being ever. He was like over 8 foot tall, 8'9" or something like that. And since he was the tallest human being, he was also the tallest Boy Scout ever on record. Look how tall he is. Tall stature is usually because you're tall. You have tall parents. Okay? Very rarely is it syndromes. It can be associated with certain syndromes, but typically tall stature is because you're tall. So for example, a tall basketball player and a tall spouse will probably have large, tall children. There are some syndromes, certainly obesity can also cause tall stature. Here's one of the causes of tall stature is homocystinuria. This is an autosomal recessive disease. Remember, they do like to ask the genetics of things, or what are the odds of having another affected child. They look Marfanoid, like a Marfan syndrome, which we've already discussed. But unlike Marfan syndrome, these patients will have mental retardation and some psychiatric problems. This is homocystinuria, very rare disease. This is Sotos syndrome. It's also known as cerebral gigantism. These patients are large for gestational age. We discussed large and small for gestational age in the first chapter. This goes along with various degrees of mental retardation, and they will have hydrocephalus. You can see the hydrocephalus here, right here. These are very large ventricles in white. The patients tend to have a very prominent forehead, as seen in both of these pictures, this one in the infant and also this one in the older child. And they tend to have a kind of pointy chin. Also, they'll have epicanthal folds and a flat nasal bridge. This is Sotos syndrome, and it courses with tall stature. Now, this patient has tall stature, and we kind of discussed it on the previous chapter. We see here on the side view, very common, very easy to see, gynecomastia. We also see hypogonadism. The patient is very tall and slender, and this is Klinefelter syndrome, XXY. Now let's talk about disorders of weight. These are going to be broken down into failure to thrive, and also into obesity, the opposite end. So failure to thrive, you have a brief list of things that can cause failure to thrive. Obviously, not enough calories will cause failure to thrive. Not enough calories because they're not being given to you, because they're not available, or not enough calories because you're not absorbing them. Certainly, allergies, immune deficiencies, and chronic diseases can also lead to failure to thrive. Congenital cyanotic heart disease can lead to failure to thrive. If you're always sick, you're basically using up calories just to try to get better. Obesity, for the most part, is our own fault. We eat too much and under-exercise. We supersize our meals and we supersize ourselves. Obesity, for the most part, is because of overeating, too many calories, and under-exercising, not burning off enough calories. And a lot of it is our own faults because we supersize our meals and don't exercise enough. We may lead sedentary lifestyles and we're not burning off the calories. Certainly, there are some people who tend to be overweight. Studies show that those people tend to have more adipocytes, and those adipocytes tend to be bigger. And there are some syndromes that are associated with obesity, although very few. A lot of times parents will want you to do all kinds of exams on the baby, and all you need to do is get a good dietary history and look at the parents sometimes and explain to them that why their child is overweight.